listening to Honestly Aging by VigRHealth, a podcast where we explore what it's like getting older, the peaks, the valleys, and everything in between. In this season of Honestly Aging by VigRHealth, we're covering topics related to solo aging. I'm your host, Cheryl Praska. Let's grow old together. On today's episode, I'm joined by Kate Phelan, a board-certified family nurse practitioner. Kate holds certifications in both palliative care and emergency nursing. She has more than a decade of experience in emergency medicine prior to receiving her master's degree from Villanova in 2018. Kate believes that nursing and the ability to heal is both an obligation and a gift. She takes her job and her patients' well-being very seriously. She is a staunch patient advocate for compassionate, quality care. In addition to caring for her patients here, Kate is also passionate about her medical mission work in underserved countries. She has an ongoing relationship with a village in rural Kenya and has assisted in providing access to education, food, and healthcare to a community outside of Kisumu village. To Kate, palliative care encompasses all that is beautiful about caring for another human being as a person, not just a number. Her patient interactions bring her joy as she partners with you to work not only to add days to your life, but to add life to your days. Kate, welcome. Thank you for being here. How are you?
I'm good. Thank you for having me. I'm so excited to be here.
Absolutely. So, Kate, you are joining me today to discuss palliative care. We'll cover what palliative care consists of, how it differs from hospice care, share real-life examples of how this type of care positively impacts patients, and more. So I would love to get started by hearing what made you decide to pursue a career in palliative care?
Yeah. So it's funny. I was thinking back to my experiences, like you mentioned, my background's in emergency medicine. And I was remembering, this has to have been 10, 12 years ago. I'm sitting in the ER and one of the doctors says, well, we're going to consult palliative on that patient over there. And I said, palliative? Why are we doing that? That patient's not dying anytime soon. And it just makes me laugh thinking about if this Kate now could see me then, I would really be shaking my head. But it does highlight a really important misconception and one that I fell prey to as well. Originally, I was drawn to it because I just kept seeing patients getting pushed through the system. They were scared and they were lonely, and really only a small fraction of what was going on with their health was understood by them. And my 9-year-old always says to me, he says, Mommy, you medical people, you like big fancy words, but nobody understands what you're saying. And he's right. So I wanted to be somebody that broke that cycle, that held your hand, that helped guide you in a direction of your care that was really what you wanted it to be. And whether that's cure or comfort, that's really what I wanted to do.
And I think every single person listening to this episode will be able to think about a moment where they were with a medical provider and just were either overwhelmed by what they were hearing or maybe weren't understanding it because those big words, many of us are non-clinical, and the fact that you are breaking that cycle and making it more approachable is just so welcoming to hear.
Yeah, it's so necessary. I agree.
Kate, how would you define palliative care?
So it's really, it's very simple and very complicated all at once. It's simply the care of people with chronic conditions. So when I meet a new patient, the way I explain it is I walk in and I say, "Hey, I'm Kate. I'm the nurse practitioner. I work with palliative care. Have you ever heard of that?" And I get one of two answers. I either get palala what? Or I get, "Oh no, you're trying to kill me."
Wow.
And it's scary. The misconceptions are so scary. So I say, "Oh, good. Okay. Let me explain it to you. I'm here to tell you about it. I'm here to help with your symptom management." And symptoms can be anything from pain or nausea, those physical symptoms, or they can be fear or anxiety of a new diagnosis, or the uncertainty of navigating the healthcare system. I'm here to help support you through that. And then I say, we're going to talk a little bit about what your goals are and how we can help you achieve them. And it's really as simple as that. Like my kid said, it's a big old word to explain a simple concept. We're here at your side to help you feel better and hold your hand through it. In palliative care, we talk a lot about goals. You'll hear the word goals a lot with palliative care. And when I see my patients in acute rehab, usually when I ask them what their goals are, I usually get me the heck out of here. They
Wow.
just
Yeah.
they want to go. But sitting in silence with people is really so important too. And under that get me out of here, there's deeper meaning to that. There's that patient's telling me that they value their independence. They value their mobility. They value their autonomy. And a lot of it feels very powerless when you're in a rehab situation like that. So I get to talk to people and help find out what matters most and get them, the healthcare they need according to those values. I often say that patients, and I include myself in patients as well. We all have, seeked healthcare at some point or another. And you go to the hospital or you go to a doctor's appointment and you get a new diagnosis, and it's scary. And what they do is they make you an appointment for your next test that you need to be done. So you get the test done and they say, "Okay, well, the next step is to do the procedure." And so they schedule the procedure and then they schedule a follow up and then they schedule another test. And nobody stops and says, "Wait, hold on, pause. Is this what you want for your care? Do you understand why we're doing all of this? Let me stop. Let me explain. Let me be that pause moment for you to make sure that this is really in line with what you value." So, like I said, very simple, we're here to hold your hand, but there's a lot that goes into it.
You mentioned about palliative care helping to manage chronic conditions. Can you
Yeah.
just give us a couple examples of what some chronic conditions could be?
Yeah, absolutely. That's a great question. So a lot of people will say, "Well, I don't fit that." And it really is chronic conditions. And I explain it to patients like this. When we're kids, we get strep throat and we get an antibiotic and it goes away. It's not a chronic condition. But as we get older or young people do follow with palliative care too, because they do have chronic conditions as well. But the more common ones we see in our population are COPD, CHF, diabetes, hypertension, dementia, all of these things that can really be difficult to help navigate the system with. And with, say for instance, COPD, you go to your pulmonologist and they give you the medications and they help you feel better. When I see a patient, I take all of those pulmonology notes and I bring them in and I look at them and I read them and I help process them. But I also say, well, how has your shortness of breath impacted your social life? You used to really enjoy going to bingo at the church, but now you're worried about the oxygen tank running out. How can we help make that better? Or you used to enjoy going to church, but again, that's a really long day and a car trip. How do we help bring church to you? So there's a lot that go into this COPD or CHF. Sometimes it's help just understanding the medications and why we're taking them. Somebody said to me recently, he was in and out of the hospital, in and out of the hospital. And I was really trying to get to the root of why this was happening. And he said to me, well, Kate, I figured if they're discharging me from the hospital, I'm cured. And so we had to stop and talk about chronic conditions. Well, you're always going to have the high blood pressure. You're not cured. We're taking the medications to really help prevent other things. And he had this light bulb go off. And so to really work with people to help keep them out of the hospital with these conditions in whatever way they need is huge.
And just like you said, helping people maintain their independence and reach their goals. And to get to that point, the patients, everyone who's ever been a patient or will be a patient
Right.
included, must understand what's going on with their body, with their health, so that they can also be part of moving forward in a positive fashion with knowing how to, exactly like you said, manage whatever their condition may be.
Right. Patients, again, us included, really need to know what's going on. I want you to know what you're taking. I want you to know why you're taking it because I really want the best outcomes for you. I want your independence as long as you possibly can have it.
So my next question, I do think it is important to cover this. How does palliative care differ from hospice care?
Yeah, absolutely. I think a lot of people really mix those up. And like I said, myself included many years ago, and they're really not as synonymous as people think they are. So I like to think of palliative care as like big umbrella. And you can be seen by palliative for many, many years. Often you get diagnosed with any of those number of conditions that we mentioned, along with many others. And palliative care hops on board early. We may see you in the beginning once a month, once every other month if you're really stable, whatever you need it to be. But as the disease progresses, we see you a little more and more often to help make sure that your symptoms are well managed and you feel well supported. So palliative focuses on both quality and quantity, meaning if your goal is longevity, palliative's there to help you achieve that. When you say, for example, somebody gets a new cancer diagnosis and their goal, they're going to cure this cancer, they're going to kick it, they're going to get better. They want to do chemo, they want to do radiation. Well, palliative care hops on board early to really help with those symptoms, to help with all the side effects of that treatment, and also to really help you navigate that process and readdress your goals every step of the way. Hospice care falls under a very tiny piece under that really big umbrella that I mentioned. So all hospice care is palliative in nature, but not all palliative care is hospice care. So, say, for example, that same patient that had that cancer diagnosis has been following with palliative for years. They had a relapse, or they were doing great, life was good, but they had a relapse. And they said, Kate, I don't want to do that again. That chemo was awful. It made me feel terrible. I couldn't enjoy my loved ones. I couldn't enjoy the time that I had. I just want my time here to be without all of those symptoms. I want my time to be the best time it can be, even if it's shorter. That's where hospice comes in. So, in order to qualify for hospice, you have to have two physicians sign paperwork that says, in good faith, if this disease process runs its normal course, that your life expectancy is 6 months or less. That being said, you can recertify and stay on hospice as long as the condition is progressing. You don't, get kicked off of hospice if you're still here 6 months. And you don't, the reason we see patients that go on hospice and pass soon, because I hear this a lot from patients, is really that we're getting hospice on board too late as well. Really having early intervention, to have palliative there early and then to have hospice there early really helps you reap the benefits of hospice. Keep in mind, none of us have a crystal ball. None of us really know, okay, this is 6 months to the day. And honestly, some people do get better on hospice. You get an extra, really deep layer of support with hospice, and your symptoms are really great managed. And you have all these people really help trying to make your life the best it can be. And sometimes people get better and they get discharged, and they come back over to me with palliative. And, we follow them and help do the same thing to manage those symptoms. Another big difference to keep in mind is the insurance piece of it. So, hospice care has a benefit under your Medicare plan, and under that benefit comes a lot. So, there's nurses, there's somebody on call 24/7 if you need something, or your pain's acting up. There's aides that are coming to the house to help with your bathing or whatever you might need help with. There's social workers and chaplains who are very involved in your care, because that's all covered under the benefit. The other thing you get under the benefit is any equipment that's related to your diagnosis. So, say you needed a hospital bed or a commode, those things are covered, as well as any medications or supplies such as briefs or wipes or whatever it may be. Those are all covered under that hospice benefit. With palliative care is a specialty service. So, there is no palliative benefit. You don't go on to palliative, you get seen by palliative. I like to think of it as it's a specialty service the same way your cardiologist would be a specialist. You get seen by a specialist, it's under your Part B benefit, and it gets billed the same way any specialty doctor would. With that, the social workers and the chaplains are not necessarily covered under benefit. Now, we do have social workers and chaplains simply because it's good care for the patient. And we consult them and they're available if we need them and see that there's a need for them. But it's not something that we bill for under a benefit the way hospice would be.
Would you prefer to age independently in your own home or live in a nursing facility? I know what I'd rather do. Friends Life Care membership offers just that. Plan today for a future lived at home with vitality, independence, growth, and resilience while protecting your savings. Learn about your options at a free seminar or webinar. Register at friendslifecare.org/register or call 215-628-8964. Something that you mentioned at the beginning of your response was that palliative care readdresses your patient's goals, because the goals may change depending upon where someone is in a condition, in the support that they have, just where they may be in their life and the life events. So the fact that it's not one track for everyone is, at least for me, that is a bit of a relief to know that I can maybe change my mind. I can be a little bit looser on my plan. and have someone like you, Kate, who can help guide me and support me through it.
Yeah, I agree with you 100%. I often say to people, do you have a living will or a medical power of attorney? And they say, yeah, I did that 20 years ago. It's in a drawer somewhere. I don't know where it is. And I say, oh my goodness, well, we got to dig that out. And I know it's on paper somewhere, but we got to talk about that. What are your wishes? What do you want? What matters most? What does a good quality of life look like to you? How do we pinpoint what you want? Because it's such a fluid thing. At,
Absolutely.
at a younger age or a better health condition or whatever it may be, might want to try everything. But as things progress, you might say, oh, I really don't want that feeding tube that they were talking about. It changes. And I think patients find comfort in that too. So, one of the things I do with all of my patients is fill out what's called a pulsed form. I probably have
Mm.
one sitting at my right hand side because I always have them. Uh, it's the hot pink form. Um, in the state of Pennsylvania, and it outlines your wishes regarding CPR or intubation. And a lot of times patients say to me, well, I'm afraid to put something on there. And I say, well, if you change your mind, you say, hey, Kate, I've changed my mind. And we rip it in half and we start a new one. And somebody once, he didn't believe me. So we ripped it in half right in the room and we started a new one.
That's definitely a memorable moment for everyone involved.
Yeah, he said, "Oh my goodness, you weren't kidding." This is your life, your wishes. You all change them however you want to change them.
Yes, the patient's in the driver's seat.
Absolutely, as they should be.
So, in addition to what you've covered so far, what more might you want to say about what palliative care consists of?
Yeah, so we talked a little bit about, the benefit versus being a specialty service. So because they're covered a bit differently, the structure just looks a little bit different. So you get, the aides and the nurses and all of that under hospice. But when you get seen by palliative, it's typically one of our nurse practitioners that will come out and see you. And with that, you have the nurse practitioner, you have a medical director that is specialty trained in palliative care as well. You may hear from our MAs or our schedulers to help coordinate your care, or our nurses who are checking in with you. We do also have the social worker or the chaplain, who we can consult if we need them in those areas. So it's still a team and it's still really working to address all of your needs, but it's structured a bit differently.
Hey, where is palliative care delivered?
I was at an event this weekend and somebody said, "Where do you work?"
Oh,
And I said, "That's a good question." And
everywhere.
my answer ended up being, "Well, I guess I work wherever the patient is." And that's really the answer. Palliative care can be delivered wherever the patient is that needs palliative care.
Wow.
A lot of our patients, their goal is to stay at home. They don't want to be in a facility. They don't want to be in the hospital. They really want to age in place, stay at home, and have their needs met there. For a lot of these folks, the mobility is huge, and just getting out to a doctor's appointment requires a lot of planning, whether it's, making sure that you have a ride or that somebody's available to help you in and out of the car, whatever it may be. It can be a lot of work for people. So in that case, we come to your home, and we see you in your environment and help meet your needs where you are. Some palliative care companies have clinics like doctor's offices that you can come and see your palliative care provider there. I also provide palliative care in nursing facilities or in independent living facilities. And palliative care is also provided in the hospital setting, in ICUs or in the hospital to really help address needs there. So wherever the patient is the answer.
Many of us have a primary care doctor. What makes palliative care different?
So time, time is really one of the biggest aspects. I think a lot of healthcare tends to be very go, go, go. And a lot of that's insurance dictated. A primary care provider can have 15, 30 minutes around there intervals to see their patients. And my visits can range anywhere from 15 minutes to 2 hours or more. It really depends on what the patient needs. So we do a lot of family meetings. If, say, there's family all over the place and a lot of them have different views on what should be done with mom and how we should care for mom. And somebody says, well, I think that she should do everything with her treatment. And somebody else says, well, mom just wants to be comfortable. Why are we doing that? We really bring all of those people, the specialty providers, the pulmonologist, the oncologist, whoever it may be that's involved in that care. And we bring everybody together and have a family meeting to work through these issues, to figure out how to best serve the patient, the family, and work together. So those can take a while, and we have that time to do that. We're also specialty trained in different communication techniques, delivering difficult news, and really taking deep dives into advanced care planning. And, we use these words, advanced care planning, again, big fancy words. But what that means is CPR, intubation, ventilators. But beyond that, we take an even deeper dive. Do you want blood draws? Do you want feeding tubes? Do you want surgery? What kind of testing do you want? If that testing's done, what are we going to do with it? So we have that time to really dive into those big issues. And we don't replace your primary doctor at all. A lot of people have a primary doctor that they know and they love, and they've been following him for 15, 20 years. And I want you to have that. We're here to work alongside your primary care doctor. When I see a new patient, I typically pick up the phone, call the primary's office and say, hey, I'm Kate, I'm from Palliative. I'm seeing Mr. So-and-so. I just wanted to introduce myself and tell you a little bit about what I do so that we can work together to help serve, our mutual patient. So we work alongside them. They steer the ship. They're still your primary, but we're just an extra member of your team.
I'm thinking about all of the training and experience and education individuals who work in palliative care must need in family dynamics and team dynamics because the the group that you just spoke about, it sounds very diverse to have different family members and different healthcare providers all in a room or on Zoom or on the phone. And I can imagine each person advocating for what they think is the best path, and the palliative care provider having to really bring things back to the patient. That's what I'm envisioning. Is that right at all about what you deal
Oh
with?
yeah, that's very accurate.
Okay.
That's very accurate.
Yeah.
It is. And, people have their beliefs, and under those beliefs are a lot of really big, difficult emotions too. It's not just, is this red or blue? It's, I love my mom and I have these feelings. Feeding tubes are a huge conversation because food is so ingrained into our culture of caring and love and nourishment. So people have very strong opinions on that. So to listen to what they have to say, recognize, their opinions and their feelings, even if they're not delivered in the most kind manner sometimes, um, to really recognize that there's pain under that, and then talk to them about what the evidence says and, what might be best, the risks and benefits, and when they're ready to hear that and have that conversation. Sometimes it does take several appointments and visits to really kind of nail down what we're working towards.
Can you talk about the Angelic Health palliative care team and what sets you apart?
Yeah. So I have experienced several different palliative care companies, but I must say I have been so impressed with Angelic Health. I'm blown away with their team because I think they've really paid a lot of attention to building and growing their team. And everybody here from the ground up just does everything patient focused first. The schedulers, the MAs, the nurses, all the way up to the CEO and the ownership and upper management, everything they do has compassion in the forefront of their mind. And I don't see that with a lot of companies. We also have some pretty cool, unique specialty programs that we've developed to really best serve the needs of our patients. So we have disease specific specialty programs designed to help manage the symptoms of that disease process. So we have a CHF program, we have a COPD program, we have a cancer program, we have a high risk program, which is really cool. So if a nurse practitioner identifies a patient as a high risk patient, meaning they're they have symptoms that aren't well controlled, or they recently had a change in their medication, or they're at risk for falling, or at risk for going to the hospital. We have a nurse that reaches out every Friday as we're going into the weekend to make sure that they have everything they need going into the weekend, where it may become more difficult for them to reach their primary care doctor. To if we identify anything that really seems like, oh, they say to the nurse, I'm really just kind of feeling more short of breath today, or whatever it might be. The nurse practitioner then hops on a telemed call and addresses those symptoms. So they're not going a couple days, thinking, oh, I don't want to bother anybody with this. We really get ahead of it to keep those folks out of the hospital. Another thing we do under our disease specific programs is a memory care program, which I just think is phenomenal. So we've partnered with All's Better to deliver these memory care visits for our palliative care patients. And like I had mentioned before, dementia falls under that chronic care, the chronic conditions that we help manage. And dementia is difficult, and being a caregiver is really difficult. And a lot of times I talk to people and they feel so lost and overwhelmed, and the person that they're trying to talk to, they're just not getting the same response that they're had gotten for the past 30, 40 years, and they don't know how to cope with that. So what we do is we meet with them in palliative and we talk to them and help manage things. But we also provide a dementia coach that meets with them as well and works with the caregiver to work on de-escalation techniques or how to best communicate. They help, for a patient that might be kind of getting agitated at night or staying awake and really ramping up in the evening, they work to find activities to keep them busy and engaged during the day. So they're not napping. They work with the family members to talk about how to de-escalate that and how to support them and how to create a relaxing environment for bedtime to really kind of normalize that sleep wake cycle. So it's just a huge source of support for these folks.
And I'm thinking about our solo agers, especially who are listening to the episode, and about all of the specialty programs that you provide, maybe a way to connect. And I'm thinking about that Friday check in where
Yes.
someone who may be living alone may look forward to that Friday check in, having that connection. And it would feel reassuring to know that there is someone out there that they can rely on who is checking on how they're doing.
Yeah, I think palliative becomes that in a huge way. I get a lot, oh my goodness, Kate, I'm so glad you're here. I know that you care. I know, you're here to support me. And people are very grateful. And absolutely, it can get lonely and scary when you're, aging alone. And to really have somebody there that genuinely cares and is checking in to make sure that you're safe and secure and you feel safe and secure going into that weekend it's huge.
So throughout our conversation, you have given a few of these examples. And I'm wondering if you have any more where you can tell us about some of your palliative care encounters and how this type of care has impacted the life of your patients.
Yeah. So I've changed some of my folks' names that I was thinking about, and I went through and I used names of all of the people that work at Angelic Health. So I'm sure they're going to love that. So one is Dan, and I met Dan in the rehab facility. He's, in his 50s, 60s. He's younger. He has really lived a very energetic lifestyle. He's very independent, but he's the one that had been in and out of the hospital a couple times. And he's the one that said, "Oh, I thought things were cured when I was discharged from the hospital." And this one particular hospitalization, they had informed him that his prostate cancer that he had been getting much worse and it had moved. He had now had a catheter, a suprapubic catheter, which is a catheter that's inserted kind of in the lower belly there to help drain urine. And he was just very distraught over all of it. The catheter impacted his quality of life because he had been looking forward to dating again now that he was out of the hospital. And that was a huge source of stress for him. And I had walked in and I said, "Dan, how's it going?" And I'm Kate, and, went through my spiel. And he said, "Well, all of these people, they want me to treat this cancer, and they're telling me I need to treat the cancer and it's getting worse and I have to do it." And I said, "Oh, okay. Well, let's talk about it. What does a good life look like to you? What do you want to do? What do you want to accomplish? I'm going to read the oncology notes and see what the odds are of this really working for you, or what your quality of life is going to look like on this treatment." And it came to longevity wasn't necessarily what he valued most, but quality was what he valued most. And he said, "Kate, I just want to go to the Yankees game and I want to eat a hot dog and I want to drink a beer and I don't want to be sick with chemo and all of that. I just want to enjoy what I've got left." And I said, "Okay." So, he made his decision not to treat the cancer. But that doesn't mean he necessarily is in line with hospice. He still had COPD, and his COPD was pretty severe. He had some pretty severe shortness of breath. And he said, "Kate, but this shortness of breath is going to make it very hard climbing those stairs at Yankee Stadium." I said, "Okay, well, how about this? We follow you for palliative. We help support you, help minimize your shortness of breath, help get you to that Yankees game, help you live the best life that you can. And as that cancer progresses, we're here. We're here to help support your symptoms. We're here if it causes pain or discomfort. And if and when hospice is in line with your goals of care, we're here to help you with that decision too." So he's one that really stood out to me recently. Another one would be Sheila, who happens to be our director of palliative care. She got the name on this one, but we have this. She's a pulmonary fibrosis patient, which makes it very hard to breathe. And her main symptoms really anxiety, that breathlessness, and with anybody that's got COPD or pulmonary fibrosis, any of that pulmonary component, it really not being able to take a good breath causes so much anxiety. So you get stuck in this loop and you don't know if you're anxious because you're short of breath or you're short of breath because you're anxious. And it kind of really spirals. So she was a great one that in the beginning, we started getting calls on the weekend often. "I don't know if I need to go to the hospital. I think I need to head in. I'm not sure. I'm really having trouble breathing." So we added her to our high risk program and we check in with her on Fridays. And "Hey, Sheila, how are you doing?" And it really turns out that that phone call makes a huge difference. Like you said, it just knowing that somebody is there and supports you and can talk through your symptoms going into that weekend has made a huge impact. This particular patient also is a former pastor, and after getting diagnosed with this illness and really having mobility limited due to it, really kind of lost touch with the church. And that had been such a huge part of her life for so long. And we ended up reaching out to our chaplain and saying, "Hey, listen, I think some of this anxiety is also related to a deep spiritual disconnect." And we look at people as a whole person. Your spiritual well-being is important, your physical well-being is important, your psychological well-being is important. So to be able to get the chaplain in there to sit and meet with her and talk to her and pray with her really also helped reduce those symptoms. So it's not always throwing a pill or a medication or an inhaler at things. Sometimes it's really just that personal touch to help with the anxiety, to help with the spiritual deficit, to really support somebody as a whole person.
That social connection can have such an impact on a person's life.
Yeah, it's huge. It really makes a big difference. And I'm so grateful to be in such a position to have these conversations with people, to really support them through these difficult times and let them know they're not alone in it.
So that is all of the questions I had prepared for you. I do want to see if there is an imparting message or any imparting words that you would like to leave our listeners with about palliative care.
Yeah. Hmm. I would say we're not as scary as it sounds.
You are certainly approachable.
I really, that word tends to be so scary for people because it's such a misconception. And we're here to support you. We're here to make your care what you need it to be. We're here to help find what symptom is most important to you, what matters most to you, what your goals are, what you want from your life and your care. And we're here to help you achieve that. So I think it's a wonderful thing.
Hey, thank you for sharing your wealth of knowledge and personal experiences about palliative care. You've done a beautiful job creating awareness around the topic and its impacts on patients and their loved ones. Thank you.
Very welcome.
Thank you for listening to Honestly Aging by VigRHealth. You can find links and show notes from this episode on our website at friendslifecare.org/podcast. Thank you to Kate Phelan for joining us today. You can learn more about Kate on LinkedIn and Angelic Health by visiting their website, angelic.health, Facebook, LinkedIn, and YouTube. Links to all these resources can be found in the show notes. If you like our show, please rate, review, subscribe, and join us next time. To learn more about aging with vitality, independence, growth, and resilience, subscribe to our blog at friendslifecare.org/blog.